hit the record button to make sure I do not forget to do that. And we are still waiting on Dr. Harris to join us, but I'm going to go ahead and share my screen and start our introduction. So hopefully everyone is seeing the slides. Good afternoon, I'm Kristen Flewitt. I'm the Senior Quality Manager here at the Ohio chapter of the American Academy of Pediatrics. I want to thank you for joining us today for the third webinar in our Pediatric Psychiatry Access Line webinar series. Today we're going to have a very informative presentation about psychopharmacologic interventions for depression and anxiety in a primary care setting. Today's session will be recorded and you will receive a link to the slides and the recording. We want to give a huge thank you today to our program sponsors. The Ohio Department of Health, the Ohio Department of Medicaid, Ohio's Medicaid Technical Assistance and Policy Program, and the Ohio College of Medicine Government Resource Center. We have a few housekeeping items that I wanted to mention. Please make sure that you stay on mute to minimize any background noise. We will be monitoring the chat for questions and we'll also have some time at the end for questions and comments. Please remember to turn on closed captioning if you would like. Also, just to let you know, the Health Resources and Services Administration, also known as HRSA, provides financial support for OPPAL. You can read on the slide the amounts, and the contents of today's presentation are those of the authors, and they do not reflect the policies of HRSA or the U.S. government. And let me just check to see if we have Dr. Harris with us. I'm not seeing her yet, so hopefully, there she is. I think she just popped into the waiting room. Hi, Dr. Harris. I just started us off, so I am going to continue with our introduction.
Can't get it to connect to my hearing aid. So.
And just a reminder to please make sure you are on mute if you are not the speaker. So today's speaker is Dr. Emily Harris. She is an outpatient child and adolescent psychiatrist at Cincinnati Children's Medical Center with over 10 years of experience as a pediatric primary care physician. She has a special focus on early intervention and treatment of mental health risk factors and improving awareness and prevention of mental health disorders in youth, childhood depression and anxiety disorders and ADHD. And Dr. Harris has just been instrumental in helping us launch the OPPAL project. So we're very grateful for her, for joining us today. Just a quick disclosure, the planners, faculty, and others in control of content have no relevant financial relationships with ineligible companies. And the presenters have considered the Ohio AAP Speaker Toolkit standards in preparing this presentation. It is their intent to foster respect, belonging, support, and accountability. If you should have any concerns or comments, you may contact Dr. Kelsey Logan at the email on the screen. And as I mentioned, you will have all the slides in follow-up. Today's learning objectives: to gain understanding in the optimal utilization of first-line pharmacotherapy in pediatric anxiety and depressive disorders, and to recognize and address adverse effects of SSRI medications. And with that, I'm going to toss it over to Dr. Harris, who can speak a little more about her work, and we can get started.
Great. Thank you so much for having me, Kristen, and the OPPAL team over at the Ohio AAP. I'm really fortunate to be here and love this kind of work that we're doing. So I'm excited to represent. And I just want to apologize. We're having like a system-wide, oh, hey, thanks, Haley, a system-wide issue with Outlook. So it was like, a nice surprise. But moving forward, I did want to take some time to orient you a little bit. The Ohio AAP, and actually the AAP Mental Health Toolkit is available online, and it has some really great resources that can help. And we'll be referring to these resources throughout the talk, but common elements is something that's specific to pediatric primary care that we'll get into a little bit more, but also the Ohio Minds Matter is the website that we're using across Ohio to support both like professional resources, but also parent resources as well. And that QR code is listed on this slide. But I do want to level set first off about the role of the pediatrician or the pediatric primary care provider in the medical manager role. So, one of the big things is like having worked as a psychiatrist and a primary care provider, the goal is not to make you a psychiatrist. The goal is to help you kind of feel more comfortable initiating some of the first line interventions and making adjustments, and then knowing when a psychiatrist is going to be important to access. So, the kind of concept of starting off with your role as the medical manager is, to provide some education and information about what you're treating, and, think about any brief interventions, because one of the biggest goals with treating mental health is teaching self-management skills. So recognizing when something's happening and giving the kid more tools in their toolbox to manage distress, as well as know when to seek help. So the office can also have the next level of education in terms of there's the outpatient evidence-based psychotherapy. So thinking about psychotherapy as well as medication management options can be offered in primary care. And then, highlighting the family strengths, like these are the options that we're doing. You're doing a lot to make sure that your kid is getting healthy, and we're here to kind of think about the whole health of your child. Let's follow up and talk about this again. So following up and reassessing is the other critical step that we often kind of overlook, but we'll talk about it more here. Next slide. Switch. All right. And I think I'm able to switch to my computer. So I will do that. Great. Thank you. And so thinking about thinking about red flags, like when to consider talking to a psychiatrist, or when it's important to think about it. It's not in primary care. How do I get to the full view? Because I need to see the view, not the slides, because they're doing the slides for me.
This is like the normal.
Is that
1 second, we're solving some problems here.
All right, thank you. Sorry about that. But the idea of if there are some things that you're noticing in the interview or in the history that might want to, consult with a psychiatrist sooner than later, definitely repeated substance use, especially if it's the first use is under the age of 12, disordered eating patterns, suicidality or self-injurious behaviors, even repetitive thoughts, because the concept of like Tourette's disorder, OCD, autism, these are all really tricky to tease out. And thinking about if some of these things are flashbacks, like this might be indicating trauma, these are definitely things to consult with a psychiatrist unless you've had additional training on how to manage these in your own practice. Family history of bipolar disorder is not like a contraindication to treat, but it is recommended to kind of connect with a psychiatrist if you are initiating treatment. And this is where OPPAL can be very helpful because they can help work with you and help kind of monitoring and like what to make sure you're paying attention to when you're treating a child that has this high risk, and then how to kind of elevate the care when you need to, or at least like know what the intervention is while you're waiting for the care to be elevated. Psychosis is something we're definitely seeing a lot more frequently in primary care, especially with the THC cannabis use. But thinking also about those situations where they're kind of like having some disorganized thinking, or it's like not quite right what they're thinking about anymore. There's a change, some paranoia, something like that. But also, a decreased need for sleep or pressured speech is often like a very classic concern relating to something more significantly a serious mental health issue. Yep. So I'm not going to touch on this too much because you guys have had I think, okay. Had some interventions on this or talks about this before, but identifying and kind of detecting risk of common pediatric mental health issues, such as like pediatric anxiety disorders or depression, major depressive disorder in kids, are done through screening and interview. So the big thing is like, the interview. But here, thinking about the approximate severity, they kind of fall into the similar patterns of what you do at each of those interventions. And we talked about like some, strength-based or like preventive brain health components, education, understanding what it is when they're at risk, and then helping to problem solve as well. And then active monitoring when it starts to become more of a more of a moderate to severe level, when an active evidence-based intervention is recommended, and thinking about what that looks like. And so we're just going to talk mostly about medications today. All right. So we talk about mild, moderate, and severe disorders, but we don't really talk about what that means. And I think often it's, when you first diagnose it, the implication or the kind of expectation is that it's at the mild range. And I want to just pause for a few minutes here to kind of think about what actually is a mild mental health disorder. And in a mild mental health disorder, they actually are functioning okay overall. And they're just having at least like a single impairment or a single area that they feel impaired in. And the distress isn't leading to anything like significant, but it's causing some distress in the child internally. And these are internalizing disorders a lot of the times. And the caregiver might express there is something not like a little bit different, but don't know about it. Like that literally is mild disorder because it's causing impairment. And these are the best to get CBT or that cognitive behavioral therapy in kids started to get that skill building component to intervene with an evidence-based treatment. So that's like thinking about it. Is there like a little bit of impairment happening? That's when we start like the like kind of intense, honestly, CBT to get that kind of dialed down to give them some self-management skills. Moderate is like when, they're okay sometimes, but when they do have like impairment or it's like severe and maybe one, but like there's like several areas. So they're like having trouble sleeping, they're pulling away from friends, they're kind of grumpy, irritable on top of those things. Like that's really the moderate level of impairment related to a mental illness that we're looking at. And usually, if they're having a difficult time, other people will notice, but for the most part, you don't notice unless you know the person really well. And then versus severe, when there's like moderate impairment in most areas, the social areas particularly, or really severe in one. And this is when like the family and other people who don't know the child know that there's something distressing happening for them. So it's causing significant interference with functioning. So those kids, think about those school refusal kids. That's severe. Okay. Evidence-based interventions, and I kind of hinted about it already, but for pediatric anxiety disorders, pretty much from the ages of 6 and older, the core feature of a pediatric anxiety disorder is avoidance. So the concept of exposure is the intervention that is evidence-based. And go ahead and click it again. And thinking about major depressive disorder, the core feature is withdrawal or like isolation. So the intervention is behavioral activation. And that is like a tiny little step that they can do to get a little bit of that dopamine hit, a little bit more of that positive reinforcement. I can do something, because depression makes you feel like you can't do anything. And both of those are best treated therapeutically with cognitive behavioral therapy. And this is for all severity levels, from ages 6 and older for pediatric anxiety disorders. And actually the great thing about major depressive disorders is that there's also an alternative treatment, is interpersonal therapy for adolescents. And I think about that particularly when I have those athletes who break or get injured and can no longer be an athlete, like their identification of themselves is shifting. Or if your parents are divorcing or separating, or, a sibling is moving to college, these major life transitions that the person's going through affects their interpersonal relationships, and how if you help repair those relationships and do some role playing and some social coaching, your mood actually can shift and improve. So that's why it's like the other part of that treatment is kind of that relational component to social connectedness through interpersonal therapy for adolescents. So for the best, though, for moderate severity and higher, so when there's like an impairment that is impacting their functioning, and higher, combining both medication and CBT for ages 6 and older is the recommendation for intervening. And we talk about like why to intervene, but also the risk of not treating is an important aspect. So the risk of not treating is that often it can get more severe and the impairments can compound, and those automatic thoughts that are related to the anxiety or depression can get more cemented. And they're also their ability to have adaptive coping strategies to manage these big feelings do not improve, and they're going to miss out on important social emotional milestones. And I think we all realize that, conflict resolution and distress tolerance are two things that kids are going to need in the future. So these are things that are going to be very hard to do if they have a major depressive disorder or a pediatric anxiety disorder, impairing their ability to have that social interaction. And it's the earlier you intervene, like when it's at that at-risk or mild stage, honestly, the less need for medical intervention. So getting these like self-help skills and these management skills on board of those exposures and behavioral activation components can really actually reduce the risk of needing medical intervention. But often by the time they get to primary care and they're presenting with this issue, I have a concern about anxiety. It's usually at the moderate, if not severe level by the time it gets to us. So we're kind of missing a lot of these mild to moderate kids that are like, that would be great with these like management skills. But hopefully with the, screening processes that we're doing, we're going to be able to pick up these kids a lot sooner. And this is based on these guidelines through the GLAD PC guidelines, or the guidelines for adolescent depression in primary care. Go ahead. So we talked about this, this idea of like what your role is. So detecting it, educating, providing some self-management, but also offering the evidence-based psychotherapy or medication options, highlighting the family strengths are kind of where we're going to like have this core repetitive piece. But once you find this like shared like decision about treatment, like where is the treatment going to happen, who's on the team, you offer the options. Family decides what the next step is. This is the concept of a shared decision-making plan that I think a lot of us know how to do, but just wanted to highlight it here. Go ahead. So with the medical management visit in particular, this is where you want to assess progress. So you have goals for treatment, and you can hit the animation a couple more times, I think. So you have goals for treatment that you did an intervention for, right? So then you want to elicit, were there any obstacles? Is there any problems with adherence, or is there great things with adherence? You want to quantify functioning in terms of those elements of functioning that we do in our primary care well checks, like, the sleep, social, family, education, appetite, and activity. Those are all things that we want to assess in the medical management visit. So it's not very different than what we're already doing. It's just in a more quantified way. So instead of asking, how are you doing with sleep? Asking very specific quantification questions. And thinking about, when you're doing this medical management, you have those 5 areas of functioning, but then also like your somatic symptoms that happen, because you have to make the assessment if it's related to the medication or not. And it's not up to the family to have to decide that. So it's more about like, if they have a symptom, what might be the etiology, and making sure that you're detecting if it could be related timing wise and like the way they're describing it, if it's related to the medication, even in a good way or a bad way. And so you're going to take this like data from the screening tools, any like comorbid concerns or somatic concerns, looking at the progress and impairments and the functioning that's happening. And that's what's going to drive your decision making about what to do next. So some like tips about how do you assess this like functioning quantitatively? This is something that I literally made up, so this is not evidence-based. But thinking about how you ask questions, you can really ask a very general question, and at times that is appropriate. But there are times where asking a really specific question will get you the information that you need a lot faster and more precisely in terms of how you need to understand what they're responding to. So if you ask a kid with anxiety, how do you sleep? They're going to say fine. Like they know the socially appropriate answer. You ask about friends, friends are fine, everything's fine. I'm good. I have no more anxiety. I'm good. That is like literally the script that these guys get before they even walk in your room because they want to please you. It's part of the disorder is to avoid any problems, and they're going to avoid telling you as well. Is it easy or hard to sleep at night? And is it easy or hard to stay asleep? Might be a better way to ask questions about sleep. Or how many nights a week do you wake up and have a hard time falling back asleep? Specific questions like that can get more detailed information quickly. One of my favorite questions about anxiety, this is like from Jeff Strawn and a few other people, is are you good at worrying? Like, how do you turn kind of a negative concept into something that is considered positive? And I have to say, like a lot of kids that do have a lot of worries, you'll be surprised by how many things they can tell you immediately when you ask that question. Often it's like, oh yeah, I'm really good at worrying, or whatever word they use, like anxiety, nervousness. These are all things that can help elicit the information. And, does worrying that something might happen get in the way of sleeping or learning or something like that too is another great way to kind of pull it out because it's anticipating the fear of harm when in a disorder there is no harm. Like it's like an anticipated thought that's happening. So that's kind of my cheat sheet or kind of another way to think about how to ask questions in a more really specific, concrete way. So the medications that are FDA approved for pediatric disorders, especially the major depressive disorder and generalized anxiety disorder, it's actually pretty limited. I think ADHD is way harder to pick the medications, and there are more medications than this, but I wanted to highlight the ones that are FDA approved because those are really what's expected or anticipated that primary care should be able to initiate without significant supervision. It is fine if you have never done this to call. This is the whole point of OPPAL, is to get that supervision as you need it to help feel more comfortable with it. But these like particular medications are commonly acceptable and exactly have the most evidence of treating pediatric mental health disorders, specifically major depressive disorder and generalized anxiety disorder. And in major depressive disorder, fluoxetine is actually FDA approved down to the age of 8. Down to the age of 8. So for kids that are really struggling with a mood or a major depressive disorder, I feel very comfortable treating it if it does need medication, if it's at that severe level. Escitalopram is FDA approved for ages 12 and older. And we often off-label use sertraline in this case that does not have FDA approval in kids other than OCD, but it is often used in major depressive disorder, especially if there is something like a comorbid anxiety disorder. So moving to the generalized anxiety disorder components, previously in the past, duloxetine was the only one, and that's Cymbalta is one of the brand names for it, but duloxetine is the only one that had an FDA approval for generalized anxiety disorder down to the age of 7. But escitalopram, actually a year or 2 years ago, just got FDA approved down to the age of 7 as well. So now we have like one of those first SSRIs that is kind of our first line go-to for anxiety disorders in kids. Off-label, we still use as first line fluoxetine and sertraline as for pediatric anxiety disorders where this is kind of listed, but also they're very effective for social anxiety disorder, separation anxiety disorder, and generalized anxiety disorder. And those are the three like most commonly seen in pediatrics. They are FDA approved for OCD and for sertraline down to the age of 6 and for fluoxetine down to the age of 7. So if you'll notice, like fluoxetine is actually really great at treating both depression and anxiety, as well as the other medications are as well. The SSRIs are definitely first line. Duloxetine is a second line agent, and it has other reasons why we wouldn't use that as first line, mostly because of the side effect profile with it. And the tolerability, especially if a kid misses a dose, is pretty tough with the SNRI medication. So first and second line are still SSRIs, fluoxetine, escitalopram, sertraline. And for second line, a different SSRI. And then third line, we might like consider reaching and grabbing duloxetine.
It could also be a second line if maybe a parent has a family history of doing really well on the medication, then I would probably reach for it sooner than later. But that's kind of like why that's FDA approved, but still not first line medication. All right. And for primary care, it is not recommended without psychiatric consultation, but really not recommended to initiate desvenlafaxine, paroxetine, citalopram, venlafaxine, or bupropion. And these are medications that are not like paroxetine has some FDA approval, but for risk of suicidality for venlafaxine and in the paroxetine, but also because of the side effect profiles are really high, and there's no FDA or I'm sorry, there's no like evidence really in kids that they're extremely effective. Desvenlafaxine will always be in that green category. If some of you are familiar with gene site testing or pharmacogenetic testing or AssureRx, any of those things, and this is above and beyond what we're going to talk about in this course, but it is always in that green category because of the way it's manufactured to be metabolized in the body. It actually doesn't tell you anything about the effectiveness of the medication. So it is just to kind of throw that in there, it's often listed in the green, but really the evidence base is around fluoxetine, escitalopram, and sertraline for first-line medications in these pediatric disorders. All right. So before starting the SSRI, we talk about what happens at the end. So thinking about like how you're going to come off. So when we talk about it, we get really clear about the goals first. And when we think about when we start talking about like decreasing the SSRI, you really want to have the goals met, which means there's no longer significant impairment happening. So if you remember the whole point of a disorder, the whole definition of the disorder is around there's impairment that's getting in the way of functioning. So when that impairment is gone, like the scores are under 5 or their symptom remission and they're actually functioning well, they're handling those stresses with like those positive coping strategies and it's helping and effective, that's like when we start counting. So that's when the maintenance starts, is when they're high-fiving you, everything's like literally good and they're doing well as they're going to be. And that lasts for like more than 6 to 12 months before we start tapering it off. So parents often will come back like, well, we started it and it's been 12 months. It's like, well, they actually didn't get better until we got up to the dose on the second medication that was at a therapeutic level. Now they're doing well. It's been only 5 months. The risk of coming off sooner than 6 months is that the symptoms can relapse. And the whole point is to help kind of solidify those healthy pathways and get the kid in that kind of better brain space before tapering down on the medication slowly. So that's kind of where I give parents and the kid the heads up. It's going to be about like no sooner than a year, but we'll try and get there as quickly as we can and then kind of hold steady, even if you're feeling better. So one of the other goals is that the patient can actually recognize when the relapse symptoms are happening. And that's developmentally, it depends on the kid. But if they're able to kind of tell you what the target symptoms are, but also like how do they know if these symptoms are coming back is another good strategy to understand like if you're kind of ready to talk about cessation. And self-management is really the goal because especially with anxiety disorders, this is not something that comes and goes. It's like something that comes and you have to manage. So you can't like cure it, but you can manage it. So when they're able to have these management skills and practice and be successful in them and tolerate that distress, it will help improve their chance, like kind of help improve the chance of them not needing medication, but also like it helps their kind of recovery process and kind of getting over, getting through this anxiety in a much healthier way. So reviewing the tapering plan, I'll touch on it here, is that when you do start to have a taper, thinking about, in a head, I think about like 4 weeks or so for the receptors to reset. So I would just go down pretty slowly and there's no rush, but every 4 weeks, just dropping it a little bit more and kind of waiting and seeing. And if the kid is like able to do those self-management things, they're kind of still like working on those things to help them function, then you can go down a little bit more, the next month, the 25% of the dose or so. And this would happen even if they're on fluoxetine. I would still kind of go this like slow tapering route, just depending on what the goals are, what the severity was prior to starting. But also just thinking like if the symptoms come back and it's like causing a lot more distress and the impairments are returning, we just go back up to the dose they were on before and we just hold steady there and wait a little bit longer. It doesn't mean they can never come off a medication, it just means like not right now. And there's a whole host of reasons why that can happen. So I also think about like warning signs to talk to or contact the office, right? So like the box warning for suicidality, it's given to all antidepressants, including atomoxetine, including aripiprazole, including all these other ones that we don't think about traditionally as antidepressants. But it's really, no associations were found in the first line medications that we're recommending. And I think that's important to stress to families. And, untreated or undertreated pediatric mental health conditions is an independent risk factor for suicidality. And that's even, ADHD, like the impulse control and things like that. Like treating these early and quickly and giving them healthier coping strategies is going to reduce their risk for suicidality in general. Teen proofing is also something I talk about quite a bit in terms of this universal practice. So even if there isn't like risk that we have like overtly talked about, teens don't make great decisions and they're very impulsive and they don't even have the capacity to understand long and short-term consequences. So thinking about teen proofing your environment is kind of just standard anticipatory guidance for all levels of teens that come across your pathway. But thinking about ways to kind of reduce their access or restrict their access to something lethal is the goal, frankly. So then, having these conversations with the patients and like even the caregivers, have you had any new or more recurring thoughts of wanting to die, or just having these conversations about death and suicide or death by suicide is a pretty powerful way to kind of stress the importance, but also have a really clear conversation around it. But we can get into that in a different talk. So thinking about activation, this is actually something that can happen with the SSRIs, and it's probably more common than anything. But activation is a really specific thing that can happen where they're having trouble. Kids like soon after taking the medication can have like increased insomnia or difficulty restless sleeping, feel more activated, have energy, kind of talking more, being more silly. Like it was just very different, or maybe they're more angry. It's like just different than where you were hoping to go when you started the medication. Go ahead and hit the little button. And then thinking about like that's usually, especially if it's in the first few days, is usually dose related. So giving parents a heads up that this could happen, then you can like dial down the dose, or maybe even just try one of the different SSRIs if the kid's not tolerating it. But thinking about really low dose related concepts like that every time you make a dose change, if they're having these activation signs early on, like dial it back down and go a little bit slower next time. GI symptoms are probably another common thing that happen, and it's like those fluttery stomach feelings or maybe looser stools. You make most of the serotonin in the gut, so it's really common for your gut to respond when you take an SSRI or change the dose. The good news is that those GI symptoms usually downregulate in about like 4 to 5 days. So I tell parents if it's lasting more than a week, let me know. Or if the kid can't tolerate it, let me know. But usually it does, it's like common, it gets better. And if it happens, it kind of might even indicate that they're going to have a good response to the medication. Usually that's the first few days after changing a dose, but otherwise it's a pretty brief concern that happens. It shouldn't happen like a year after taking the medication. All right. And I also want to talk, especially with adolescents, about sexual side effects of the medication. It can like decrease your libido or kind of make it harder to have a climax or have an orgasm. And for a kid that's like understanding sexuality and experiencing themselves or kind of having relationships for the first time, this can be really confusing and like they wonder if there's something wrong with them. And so if these side effects are happening, to let you know would be a helpful way to kind of help mitigate that distress. And that's usually dose related as well. All right. So this is a primer that is going to be available to you. And it has just the basic starting doses of SSRIs that we use, we call it the big three: fluoxetine, escitalopram, and sertraline. And it talks about like the FDA approved and the common uses, as well as like the initial dosing, titration, like pattern of how high to go up, but also the therapeutic doses, which is really what I wanted to stress here. The therapeutic doses, thinking about for fluoxetine for major depressive disorder, is between like 20 and 40 milligrams. And for anxiety, they might need a little bit more, like 30 to 60 milligrams. And this would be kind of a safe zone for a lot of primary care dosing of medication. If the patient's been on fluoxetine 10 for a year, I don't consider that to be a full trial of the medication, especially if it's not working, because my advice would be to go up on the dose. But that's first line for major depressive disorder, anxiety disorder, and OCD. It has the longest half-life, and it doesn't require a taper. So if they miss a dose, it's like the kids aren't going to notice. So thinking about that medication is really helpful. Escitalopram is kind of a nice medication as well in its first line for, depression over 12, but anxiety over 7. And it can help. You can go pretty small dosing with this. It even comes in a liquid that is like down to 1 milligram. But thinking about kids, it's quick. It's easy to get to a therapeutic level with escitalopram as well. And, 10 to 20 milligrams is pretty standard for a lot of pediatric disorders. And thinking about the sertraline, starting at the small dose and then increasing pretty much every 1 to 2 weeks up until a therapeutic dose of around like 37.5 or 50 for a small kid, but 75 really for the older kids or higher would be kind of a low therapeutic dose for sertraline, depending on their metabolism. But thinking about like if they're tolerating it and they're still having symptoms, to really optimizing it to the point of, you can go up to even like 150 or 200 at sertraline, but this watching kind of following them monthly and seeing what happens. But we'll get into that just a little bit. The issues with the sertraline is that it has a really short half-life along with duloxetine. So if you're, using this medication, just be like, kind of talk to the patient about it, like how many doses do you miss before you realize you're starting to have a problem? And, usually they look like they have the flu. So they feel terrible, their body hurts, they get tired, they look terrible like they have the flu. But just ask, did you miss your sertraline? It's like one of the questions if you see them in clinic. All right. And then this is some good information also about duloxetine, which is the other FDA-approved medication for generalized anxiety disorder. And I think, taking a look at it, it has like that abrupt cessation, gets the flu-like symptoms that like, I can't tell you how many kids have come into my office like looking terrible because they have been out of it for 3 days. So counseling family about like making sure you have enough refills, making sure that you're not skipping too many doses is really helpful. But it can be very helpful, especially in like even rheumatologic pain. So like if they have other conditions that are happening, it might be useful to think about duloxetine as the second line medication. All right, so an approach. So thinking about these dosing strategies. So just in general with adolescents, starting with the lowest dose. So sertraline is 25, fluoxetine is 10, escitalopram is 5. And usually you stay on that dose for that first to see if there's any concerns about tolerability with really the GI symptoms or activation are the two things you're looking for. And if they're doing fine, or perhaps those GI symptoms came but then went away, then after that first week, I always double it. So thinking about, 10, would I go to 20? If it's at 25, I would go to 50. And then I would see them back in my office within the first 4 weeks. So that's kind of the standard approach. Usually you have a phone call follow-up or a check-in a week later to look for like suicidality or any problems with the medication for sure. And that can be done by a nurse or like your clinical coordinator or even therapist when they go into the therapy visit to kind of better assess how they're doing. But then you want to stay at that like therapeutic dose for 4 weeks and then increase the dose if you're still having symptoms or if there's still impairment happening and they're not fully up to where they should be. Because usually it only takes about 4 to 6 weeks for that to level out for where their max benefit's going to be at that dose. Often people have a little bit of a response at those first 10 days, and then the symptoms start coming back. This is normal. It doesn't mean the medication's failing. We just have to get it to that therapeutic dose so they can go a little bit higher so that it's more level in their system. And then they can see if it's going away and staying away. That's kind of how I talk about it with parents. So for younger children, it's kind of the same concept really, but you just go a little bit slower. So for younger kids or kids with comorbid anxiety disorder, I would often take that lowest tablet and break it in half, frankly. So I'd start at 2.5 or 12.5 or 5 for the medications, and thinking about staying on there is if they're younger, I might stay on it for 2 weeks instead of 1 week, but I still would go to the whole tablet before I see them back in the office at that 4-month mark or that 4-week mark, excuse me. So in the concept really is this rhythm of following up monthly until the symptoms are remitted or their impairment is like gone. That's really what you're looking for. So at the same time they're seeing the therapist, they're also taking the medication. You're checking in with them once a month to make sure that they're A, progressing towards recovery, or B, if you need to make an adjustment in the dosage, you do it and not wait like 3 months to make the change. So if you need to make a decision about medication failure, the idea of if they've been on the medication at the maximum tolerated dose, and that's of a therapeutic dose, is like either at lowest minimum 20 of fluoxetine, but really 40 most people can tolerate. But thinking about for escitalopram, usually it's around 20, or sertraline is about 150. We accept lower doses for like younger kids or kids that have slow metabolism, but they need to be on that dose for at least 4 weeks before calling it a treatment failure. You can also not tolerate a medication, and that would be a failure. But for a treatment failure of the medication, it would really have to be at the therapeutic dose for at least 4 weeks. And it takes at least 8 weeks of being on the medicine total. So these are the adverse events that we already talked about. And I just kind of had a chart here just to have it all together. And thinking about those like autonomic and those serotonergic symptoms that can happen, usually like with any of these medicines can do it, but it might be dose related, is like even these like diaphoresis or like increased sweating at weird times. Mydriasis might be a sign of serotonergic toxicity, tremor, nervousness, flushing. These are all signs that are, if they're different from baseline, it might be a sign that you just need to dial the dose of medication down a little bit or call the psychiatrist. Activation that happens about a month afterwards is one of the reasons we want to see the kids back in a month. Because if they're back in your office and they're suddenly hyper and like have a decreased need for sleep, or they're pacing in your office and talking a mile a minute, and you perhaps increased the dose, but it was a month ago, this is actually more likely to be associated with activation related to a manic activation. So these are the times that we're more concerned about bipolar kind of components, but regardless, it doesn't mean they're going to have bipolar disorder, but it is like more of a manic activation a month later. So that's when you need to stop the serotonergic components, call the psychiatrist, but getting that dose down and stopping it as soon as possible, and then kind of figuring out what is going to, like how long they recover, like what happens with that. But working with the psychiatrist at that point is helpful. It's pretty rare when it happens, but just to kind of let you know, like this is kind of this like safest way to go is to, for sertraline, if they're on a big dose, you can just drop it in half, call the psychiatrist. If they're on fluoxetine or escitalopram, just stop it and call the psychiatrist. And then have them, come back and follow up. But the psychiatrist will talk to you about it. These are some different dosing examples that are going to be included in the handout that you get with the slides, but it basically just talks about like, how to start these medications, just some dosing principles about it. So thinking about the half tab, phone call check-in, follow up in 3 to 4 weeks, and then you go to 75, 100, stuff like that. So I have it for sertraline for kids that are low dose or like before puberty. And go ahead and click it again. And then I have it for like, if you start at a low dose, but then after puberty, or if they have significant panic, how to get to that therapeutic dose faster in the older kids. And hit it again. And then if you need to rapidly taper off, so if it's, for, a medication intolerance, or if the kid is trying to, like wants to come off the medication, these are kind of some ways to, especially with sertraline, ways to kind of taper it down so that it has the least amount of impact on the child. But thinking about if it's a rapid cessation needed for mania, how to quickly get down on the dose to reduce the serotonergic feed that's happening. All right. And this is, I'm going to work kind of close to the end, but at the, thinking about emotional range and loss of motivation. If you have a kid that's suddenly getting C's and they were perfectionists before, and you're on like 150 of sertraline, that might be related to the medication. And you can kind of dial it down a little bit to see if their apathy or their amotivation improves. It's a pretty rare thing, but it happens when they're kind of like their dopaminergic symptoms kind of get maxed out, and it's a really indirect kind of function that happens, but it can be related to apathy syndrome related to the SSRI. So serotonergic symptoms we talked about is in that graph as well, but these are the really common findings with serotonin toxicity. The rapid heart rate, dilated pupils, sweating, GI symptoms are really common, like diarrhea, vomiting, things like that. That can happen, and being just agitated as well. But this is like either lowering the dose or, reducing the other serotonergic medications that might have been introduced on top of it. This is a brief slide about serotonin syndrome, and kind of thinking about the hyperreflexivity is that neuromuscular finding. Hyperreflexivity usually starts in the lower extremities, so in their ankles and up to their knees in terms of that hyper kind of myoclonic tonicity that they can have that increases the clonus. Go ahead and click it. Yeah. And the other piece is, just wanted to touch on this briefly, is, when you have a kid with comorbid substance use issues, especially if they have ADHD, there are ways to do this in a safe way, but treat the ADHD. The mood and anxiety might be related to the medication if they're using cannabis. So thinking about the sertraline and escitalopram in particular might be higher risk to use with comorbid cannabis use. So thinking fluoxetine might be a better issue, but really that's a harm reduction model and needing to kind of focus on reducing the substance exposure. And I think that's the majority of the content slides that I had.
Yes, and we did have one question
Oh,
in the
great.
chat. If they say the medications can take 6 to 8 weeks for a response, why do we titrate every 1 to 2 weeks instead of waiting?
Yeah, that's a great question. So we want to get to that lowest therapeutic dose. And this is just some extra information that I have here. So we want to go to that therapeutic dose, and that's where we start waiting that 4 weeks. So you don't want to stay at sertraline 12.5 for 4 weeks because we know that's not going to be an effective dose. So the lowest therapeutic dose for a small child, 37.5 or 50 milligrams, you want to get to that place and then hold for 4 weeks before making an adjustment. That's a great question.
Wonderful. Thank you so much. This was a ton of information, and like I said, everyone will have access to the slides, so you'll have all of this for reference. As a reminder, if you have not registered and signed up for OPPAL, we do have a slide to help you do that. So you can scan the QR code, you can go to the oppal.org website and register there. You can actually call, which is also kind of the preferred method for registering. So we have the number on the screen. And please also, if you have not registered for additional resources, please do that as well. I think we just wanted to double check. Oh, yes. Haley put that in the chat as well, the website and also the phone number for calling.
Call us. No, we answer. I answer on Fridays. My colleagues answer throughout the week, and it's great. The sites all over the state are answering, so it's really wonderful people to work with. Looking forward to
Yes.
hearing you guys call.
Yes, and so if you have additional questions, please let us know as well. And then also on the screen at the bottom is the additional link for the registering for the additional webinars that we do have coming up. I think we have 2 more. If you've not, or 3 more, excuse me, or 3 more. If you haven't registered for those, you can, again, scan the QR code or go to the website and there's the registration link. So thanks, everyone. Hope everyone has a great day. Thank you so much for all the information, Dr. Harris.
Thank you. Thank you for having me.
Thank you. Bye-bye.